glad to see we have this many escaping H1N1. If you haven't heard, our interns have had a decimation with the H1N1 this week. Half of the interns are out. Literally half of them are out right now with confirmed H1N1. So it's my privilege today to introduce Ben Wilfon, who's a professor of pediatrics and medical ethics and humanities, and Ben's going to tell us a little bit about the Truman Katz Endowed Lectureship and Center for Pediatric Bioethics, and introduce today's speaker. Ben?
Thank you, Bruder. It's really a pleasure for me to welcome you all to the third annual Truman Katz Lectureship. Looking around the room, I see a lot of old faces, but some new faces, so I have a few slides to tell those of you who don't know about Truman, to tell you about him and how he contributed to us and to the hospital, to the development of our center. Truman was the CEO of the hospital from 1979 to 2005, and he had an incredible visionary leadership and really moved the hospital to a very strong fiscal position, and also secured broad-based community support for all the hospital activities, and in particular really focused on trying to develop the subspecialty programs and having them reach out to the region. Oh, I pressed the wrong button here. So he did many things during his career, but I wanted to point out several that are really pretty notable, although now they probably seem quite mundane because they're already in existence. He really worked hard over his career to develop the relationship between the Children's Hospital, a private institution, and the University of Washington, in particular with the Department of Pediatrics. And really this has become a model for how private and public institutions can interact with each other. As part of that notion, he worked collaboratively with people at UW as well as Fred Hutch for the creation of the Seattle Cancer Care Alliance, a particular program that also is emulated throughout the country. Truman also saw his role as the leader of a hospital as not just being about making the hospital work well, but thinking of the environment in which children who are served by the hospital were cared for more broadly within the population. So he really focused on issues of advocacy related to child health, injury prevention, and early learning. And he also appreciated that it was important for the Children's Hospital to move forward in the direction of thinking more about research as being integral to its mission. I keep on doing this, don't I? Okay. So Truman had a long-standing interest in ethics. Here you can see him back when he first came here. Some of his most deepest roots were in issues related to quality of care, and also issues related to the respect of the value of families in making decisions. And as time went on, he developed this emerging interest both in clinical research as well as complementary medicine. And as he was nearing his retirement, he became committed to developing the first Center for Pediatric Bioethics here at Seattle Children's Hospital. So our center, which has now been in existence for 4 years, has a mission to try to improve the lives of children and their families by enhancing bioethical determinations in both healthcare and research. And we do this through their own research that we conduct, through providing consultation, education, and training the next generation of leaders. And we also, as part of the center, we have a endowment. Well, I should also mention the board endowed the center in honor of Truman when he retired. They also endowed a particular lectureship, which is why we're here today, in honor of Truman. And this is the third year we've done this, and it's really my pleasure to introduce Larry Churchill, who will be our third annual speaker. So I should actually tell you the story of how we came up with Larry as our speaker today, because although I've known Larry for about 10 years, Doug Deakema, my partner, actually knows him even longer, because Doug was a student of Larry's when Larry was at the University of North Carolina, when Doug was a medical student. And so last year when we were discussing who to bring out, he said, we should bring out Larry Churchill because he could talk about healthcare reform. Because Larry, as I'll describe in a moment, has worked on this issue for many, many years of the healthcare institutions and services and how they're distributed and organized. So I called Larry and invited him. He goes, well, you know, Haven't been working on that recently, but here's some other things I'm doing. So we decided to have him focus on that topic. And of course, Doug was quite prescient in appreciating that as the year would go on, healthcare reform would really become a very hot issue. But Larry has had a very long-standing and illustrious career in bioethics. After he completed his PhD at Duke in the early 70s, he was part of a interdisciplinary group of postdoctoral scholars that was funded by a program by Ed Pellegrino, who's also one of the leading leaders in bioethics back in the early 70s, and that really launched his career in bioethics. He stayed on at University of North Carolina from the early 70s until just 2002. During the time he was there, he spent 10 years as the chair of the Department of Social Medicine, which is one of several programs like this around the country. He is one of the co-editors of a book called The Social Medicine Reader, which is one of the textbooks that's used widely throughout the United States for these types of issues. Larry has published extensively. He's written numerous books, numerous papers. It's interesting because Larry is not somebody whom, at least in my mind, I would explicitly identify as somebody who specializes in pediatric ethics. But in fact, when you look at his CV, he probably has more articles written about pediatric ethics than most of us in our program. So it's really a pleasure to have him speak today. So without any further ado, Larry, let me get my, of course, this is my technical. Here we go. You are all set.
Okay. And is the forward is
That way.
here. Correct.
Don't press that button.
Don't press that button. I've got it. All right. I think I'd like to put this on because I like to move around a little when I'm talking, if that's okay. Does that work? Can you hear me? All right, great. Thank you. It's an honor to be asked to Seattle Children's Hospital, so I want to say thank you very much to Ben for the invitation to come, and also say what a nice thing it is to be honoring a person like Truman Katz, who has done so much for the local community, but also for the causes of bioethics in children's health. And so I'm honored to be here, and thank you for the invitation. I'd like to talk for about 30 minutes, and the reason for that is that I know what I'm going to say, and it's sort of boring to me to just say it without understanding what it is that you might have to say in response to it. This is how I learn, and the exchange and the engagement is part of the great fun of doing this. So I'm not going to take up too much time with this. I just want to lay out some fundamental issues and see if you can help me, because these are issues that I'm still working hard on, and even though I'm going to be talking about things we did 5 and 6 years ago, it's a continuing set of problems that I'm not at all convinced that we did the right thing. So you can let me know. This is my disclosure. Certainly no commercial products and no conflicts of interest that I can talk about in public. Here's the basic question that I really want to pose for you, and that I will circle back to in about half an hour. It comes out of my effort interviewing and working as a consent monitor for young couples who were contemplating whether to go maternal fetal surgery to repair spina bifida. And these are the kind of responses we got from the couples we interviewed when we talked about why they were here and what they understood about the procedure. I feel that God has sent me to Vanderbilt. I also did this at the University of North Carolina, so it could have been that as an educational designation. I feel that God has sent me to Vanderbilt to have this surgery, a young woman said. Or another one said, my faith will protect me from harm, so you don't need to tell me about the risks of the procedure. Another couple says, whatever happens, it will be God's will. It's really out of my hands. Why this issue? Well, I am a religious studies scholar originally, and so I've always been interested in the way in which religion plays into people's lives and plays into their moral decision-making. And I understand religion as a very broad category of interpretations and orientations to life. So spirituality would be another term we might use to describe this. I mean to include something more than the garden variety belief in a sort of monotheistic caretaker scorekeeper, but to include capacities for self-transcendence, for great depth and orientation of one's life, a sense of cosmic connectedness, however this comes across for people. So my sense is that medical interactions and interventions are weighted religiously for patients very frequently and for parents when dealing with children. And that is also religion, our spirituality, spiritual orientations turn out to be very important sources for the moral norms that people use to guide their decisions. And that, here's the reason it's interesting, I think, to continue the discussion, sometimes religious modes of reasoning and decision-making pose barriers to informed consent, so that we need to be troubled by what we're hearing, and how do we proceed when that is the case. So here's an outline of the story I want to tell you this morning. I want to describe a study that I was involved in that explored the decisional dynamics of couples who were considering enrollment in a clinical trial involving prenatal spina bifida repair. And I want to ask about these decisional dynamics. What does this tell us about moral decision making? Because I'm going to argue that we're using, in fact, the wrong model to understand this, a much too formal, too academic model. And then I want to ask about the implications for the process of informed consent, because getting a valid informed consent, most of us think, is really the first thing you have to be sure about before you do an intervention. Certainly an intervention in a clinical trial. So let me tell you a little bit about the clinical trial itself. I participated in this first at the University of North Carolina, and then I continued at Vanderbilt after I moved in 2002. It's an open uterine surgery involving a C-section procedure for revision and closure of the back in spina bifida, and it occurs in roughly the 4th or 5th month of the pregnancy. Vanderbilt did pioneer this procedure. They've done several hundred of them. One of my colleagues at the University of North Carolina went to Vanderbilt, in fact, to train to learn how to do this procedure, and North Carolina was very interested in becoming part of the subsequent clinical trial that was sponsored out of NIH. They didn't get in, but they were trying to get in. There were 3 sites for the trial. Vanderbilt was one, Children's Hospital of Philadelphia was the second, and UCLA was the third. That trial is still ongoing. This procedure is controversial because it involves intervention for a non-fatal lesion, and it involves substantial risks both to the mother and to the fetus. The long-term efficacy of the intervention for mobility and continence is unlikely in most people's view. And the chief objective of intervening is, in fact, to correct the fluid dynamics in the spinal system with the idea of delaying or perhaps even eliminating the need for shunting. Why would you want to do that? Because, as all of you know, if you can delay shunting, you think you may be able to minimize some of the developmental delays in these young children. You don't need to see this, but for an audience that isn't accustomed to seeing this, this is what it looks like. Now, the details of the UNC trial, which I want to talk mostly about, are that we interviewed 12 couples who came to the big medical center and spent 2 days talking with a variety of healthcare professionals, neurosurgeons, pediatricians, gynecologists and obstetricians, developmental delay specialists, social workers, financial counselors, a whole array of people, and my team was one of the groups that met with each of these couples. We were originally designated by the IRB as consent monitors because the IRB thought this was treating a very vulnerable population, and they were worried about their misunderstanding about the nature of the trial itself. I had 2 colleagues. One is an anthropologist, Sue Estroff, and the other a general internist, Barbara Rothschild. The study was complicated by some background factors I wanted to discuss just briefly. The first is what we came to call the wow factor. This is a procedure that had lots of publicity. There was a film made by the Learning Channel at Vanderbilt which went through the procedure and showed it, and a lot of the people who came to see us had already seen this. And so they arrived with the expectation that, well, this is sort of standard therapy. It's a sort of a miracle procedure where you go in and repair a back prenatally and then everything's fine. And a lot of people began to think of it as a kind of established therapy. There's also, as many of you know, the impulse to just do something. We have a problem, so let's get busy and fix it. There's also the desire on the part of parents, as I know you are well acquainted with, of trying to do everything possible for your child. And there are grieving rituals that complicate things, getting over the news that you have a less than perfect baby. This is a picture made at Vanderbilt. You see the fetus's hand on the surgeon's finger. This is the kind of thing that the parents who came to see us were well acquainted with. We did a 60 to 75-minute interview with each of these couples, and we were asking these kinds of questions. Can you tell us your response when you first learned the diagnosis of spina bifida? What brought you to the medical center? What is your understanding of the risks and potential benefits? What does it mean to you that this procedure is experimental? We chose this word very self-consciously because studies have shown that clinical trial or study don't carry the same kind of implications. So we want them to know this is not an established procedure, it's an experiment. And is anyone urging you to have this surgery? We're trying to get at the question about the freedom with which they are there pursuing this course of action. I want to talk briefly about 5 features of the decisional processes that these young couples went through. This is not an exhaustive list, but it's a representative list, and I hope it will serve to get across some of my points about how people in these kinds of situations make decisions. The first thing to say is that the moral decision-making of these couples was seen as a part of the overall coherence and integrity of their lives. It wasn't a single decision at a point in time. So to take it as a slice of life in which you're looking at people and asking to make a choice based on evidence and weighing of alternatives is not the kind of model that well describes what it is that they were doing. It was rather a search for coherence and integrity. Here's a quote that I hope will illustrate that. Can you read that in the back? Here's a second feature. Decision makers sought signals for how and what to decide. And the world was perceived as alive with significance and decisional clues. In a way, it's fair to say these were people who are in a kind of state of hyper-alertness in relation to what might be an influential factor. So we talked a long time about the fact that we were so nice to these people. Being in the South, you know, everybody is friendly and welcoming and wants to help them and is guiding them around the hospital and figuring out all kinds of things. I know this happens everywhere, but there is a kind of a Southern flavor to this that people were picking up on, and we said, you know, maybe this is sending the wrong message. But there was a kind of an alertness to, is this the right thing to do based on everything in the environment for them? And let me give you some examples of that. This young woman, maybe 22, she said, this may sound weird to you, but since my grandfather passed away, I felt his presence, like he's watching over us. And in my heart and in my mind, I feel he's going to be watching over me if I have this procedure done, and he's not going to let anything happen. So the living and the dead all play a role in terms of the sense about what is the larger environment in which I'm functioning and how do I read it. Here's another example. Friday, when we found this out, that is the diagnosis, and we were having all these horrible visions in our minds, we're questioning, gee, if we bring a child into the world with this horrible ailment, life is going to be horrible. And we found out that, in fact, a lot of local physicians had really hung the crepe and painted a very grim picture and suggested right off the top that people should be thinking about termination. We were debating that, and I tell you that it was interesting to look at our mailbox, and I pulled out my magazine. It's Decision magazine. It's called Decision magazine, and it says, "Your strength in the storm, and this is our faith." And so when I got that, I immediately felt, whew, all right, okay, my faith. This is why I have faith for these types of situations. Going to the mailbox and picking up a magazine is not usually the kind of thing you think is going to be some kind of sign to you about what's going on in your life. And this is what I mean by a state of hyper-alertness and a kind of strong antennas for signals of all kinds. This really complicates the informed consent, as you can see. A third feature of how these young couples made their choices is that good choices frequently meant playing a role, playing a part that you have been given and doing it well. And so once you've decided what your part is, what your role is, you can just sort of naturally and spontaneously do this. So it isn't a deliberative process. It's not like mapping out the decision trees on a blackboard and following them out. Here's a couple of examples of this kind of thinking. It's the way I was brought up with my parents. They did everything possible to help their kids. Their parents did the same thing. It's just what you do. Or another example, I don't want our child to grow up and say, well, Mom and Dad could have done something, but they didn't want to risk their own selves to do it. This is in relation to maternal risk for the procedure. And it's such an interesting thing to me to see people projecting out 5-10 years into the future and saying, I wonder how my child is going to think about the decision we're now making. And so I have to take that into account. But it's that role, it's that parental role. There's also very interesting gender differences among the couples in terms of the way they thought about these decisions that I won't talk about today, but maybe we can if there's time. So here's a fourth feature that I think is striking. Decisions were less made than arrived at. After a journey, and the path for the journey was often seen as already mapped. So reaching resolution was less a matter of deciding than of following rituals and practices that would enable location of the right path. How do you get yourself on the way so you can follow the signpost? And the path is going to be sort of out there for you if you can get yourself onto it. And so regardless of what we were going to make a decision to do, we wanted to be well-versed and well-educated. So coming to the big medical center was a part of getting on the path. So I think that coming here, our intention in coming and our belief in coming was that God brought us here. And so that taking in the information, spending a couple of days like tomorrow and Sunday, sitting down, talking about it, praying about it, that if we really felt like God was saying, this is maybe not what I want you to do, then we would say we're not going to do it. But notice the dynamics of how you're steering yourself into a right relationship. Another feature, the last one I want to discuss, overall the couple's choices were less deciding than discerning. The right place, the proper place in the scheme of things, which often meant letting go of control over decisions and outcomes. So here we are trying to encourage people to make the best decisions they can make on all the evidence that we have in front of us and getting them really fully informed. And there's a sense in which they want to step back from that and just orient themselves and find a way for this to happen for them so that they can have a sense of integrity and coherence about it. There's a real tension in these two modes of approach. Here's an example. Well, regardless of what happens, if we decide not to have the surgery or to have the surgery, if we lose the baby, well, then that was God's will. And we're just going to have to stay with that. My general impressions of these couples and many other couples that I've seen since at Vanderbilt is that they are stressed, absolutely. But they are not bewildered or overwhelmed. And these are very young people. These are people, young couples in their early 20s by and large. They're uncertain, but they're not puzzled intellectually by what they faced. They're deeply reflective, but they're not theoretical in their approaches. They're grounded. They're comfortable in their own skin if you can provide a safe space for them to be oriented. And decisions were a way of discerning or reaffirming meaning. And I came to think of this as the fundamental bottom category in terms of which we would understand this whole process as a search for meaning. And I think ethics is well understood frequently, and especially in these rather dramatic life and death medical contexts, as a search for meaning. And I love this quote from John Gardner from the Western Journal of Medicine. Meaning is not something you stumble across like the answer to a riddle or the prize in a treasure hunt. Meaning is something you build into your life. You build it out of your own past, out of the things you believe in, out of the things and the people you love, out of the values for which you are willing to sacrifice something. Okay. If this has any currency at all, if this is an accurate reflection at least of the way some parents and patients approach decision-making in medical context, then it has big implications. It has big implications for my field, medical ethics. It has big implications for what we expect and understand that patients and parents are capable of doing. So I found this lovely quote from Thomas Jefferson, the plowman and the professor. The idea that the plowman can decide cases just as well, sometimes better, because he doesn't get thrown off the track by all the formal education that he's had, all the theories, all the kind of requirements for a good decision. So if you want to dichotomize this a little, just to make the point, I think the bioethics model we've worked with frequently is a very heady kind of enterprise, reasoning through analytic, logical processes, grounded in theory, deciding by explicit weighing of alternatives, drawing a decision tree, weighing up probabilities, a good utilitarian calculation, right? What we came to think of as common moral wisdom, the things that these young couples had, they reasoned through stories, parables, hunches, intuitions. They would talk about things that they had heard their parents say that were just kind of offhand cliches, but they were very powerful kind of models for decisions for them. They were grounded in their communities and their traditions, not in their reasoning capacities. And I think what they were doing is much less deciding in any kind of classical way than reorienting. They're finding their way in a new, unknown, and very threatening kind of terrain, where they don't know anybody and they don't even know how to get down the hall, but they have to figure out how to function as themselves in this context. Common moral wisdom is a phrase, as I said, we use to describe what it is that these people had. And so just to flesh this out a little bit more, an everyday phenomenon not really appreciated very well, I think, in contemporary bioethics are our theories. The idea that many people are morally wise even though they are ethically not learned. Francisco Varela talked a little about this in his book, Ethical Know-How. In the absence of any theoretical sophistication, there is a kind of wisdom people use to lead their lives, and that's what's being talked about here. And it's common in the sense that it's something all of us have, if we've been, had a decent upbringing at all and have not been traumatized too much in our early life. It doesn't imply that we hold values in common. It just means that it's sort of like the common cold, It's just out there. it has certain kind of interesting features. The ability to reorient oneself in a foreign environment, recognizing and affirming who it is that's doing the deciding. I know we're in the big medical center, but it's still me, it's still us, it's still our family, it's still who we are. The ability to bring the moral traditions and tools that one already possesses effectively into play in a crisis. And a confidence and trust that one's moral resources are adequate to the situation. You don't have to learn a bunch of new stuff. You just have to remember who you are and what it is that's really important to you. Here's a phrase from the anthropologist Claude Lévi-Strauss, who talked a lot about bricoleurs. He said there's a distinction between the bricoleur and the engineer. The engineer makes a design, then finds the suitable materials. The bricklayer simply uses the finite tools and the materials that are available, what's ready at hand, what you've already got. So obviously, I've been hammering home here a little lesson for medical ethics, and I think for perhaps a reminder for clinicians about our sense about how people can participate in ethical decisions. And I love this quote from John Freeman, who's a pediatric surgeon of some repute. Looking back on his career, he said, "I find that I have progressed from ignorance to paternalism, through arrogance to a new humility. I am still learning how deep my own biases run and how little I really know about the lives of those with disabilities." I think this rings true for me because it's a reminder about how little I knew and how much I thought I knew about what would constitute a good decision process for somebody contemplating an experimental surgery. Another way to carve this up is to say that there's the process of deciding, making good choices and validating those because you're checking them out and you're trying to be consistent and thorough. But then there's also a process called discerning, and it's sort of like a step prior, which involves remembering, imagining, intuiting, talking, praying, a process of selecting what features of this situation are going to be important to you. And that's where the real work gets done, in my view. So ethics goes wrong, I think, when we try to analyze and understand deciding without considering the discernment that precedes it. So I'm going to go back to my original set of questions here. Do religious understandings of risk and benefit compromise consent? Because even if you think, as I do, that people make decisions in lots of different ways and it's all okay in terms of if they can really be true to themselves, get oriented, reflect their own sense of who they are and what their role is, you still have to worry about whether people are entering clinical trials not knowing what the hell is going on. And that was our great concern here. So I'm asking you to go back to these original statements and help me think through this. Do these statements, the ones I put up first and then I'll show you again very shortly, do they reflect flaws in thinking that should disqualify persons from research participation? Must such statements be probed and challenged, or is this an unwarranted sort of intervention into people's decision processes and discernment? And are these statements about probabilities or examples of magical thinking? There's a very close relationship between religious convictions and magical thinking, between fantasy and faith. So which of these is at work here? That's what we're trying to figure out. So let's take this first one. I feel that God has sent me to Vanderbilt to have this procedure. How would you feel if you were a person who's trying to assure the IRB and your investigators about the validity of the consent here? What do you do? How do you think? What would you be interested in knowing? Has this happened to you?
I was involved almost 20 years with this kind of counseling, and you're at the tertiary level. first decision is made by the obstetrician and the parents when the diagnosis is made. The majority of my data show that they terminate the pregnancy.
Can you use the mic, please?
Is he saying that the majority of people with this diagnosis terminate the pregnancy? Yes.
They do it at the primary level without proper analysis.
Yes.
And the secondary level, which we function, which is a local academic center, and those people come to us, I found out, with their mind made up. They came to get information to confirm they should terminate. That's the first group.
Right.
And they will tell you that when they walk into your office.
Yes.
The second group will do anything possible to bring this child into birth, and those get sent to your center. And the third one's asking questions. So we studied over 200 of these couples to determine if what we told them, with the maximum amount of knowledge about the lifestyle of their child, which would range from 50% mental retardation and inability to do anything in terms of mobility except wheelchair, which is the most severe component.
Right.
And those families were the same as those that we told had a perfectly good prognosis with very little doubt that they would have retardation, and they would walk well, which would be a low sacral level lesion. And there was no difference in the groups. Those that came to terminate terminated, as that we had not expected. And that included the third group that was seeking information. So what you're talking about is absolutely correct, that the decisions are being made not on what they learned from doctors so much as they are based on the various issues that you just raised.
Okay, well, you've just heightened the stake in my question then. Okay? So, I mean, what do you say to anyone who comes in for a procedure? It doesn't have to be an experimental procedure, right? Who says, you know, God has sent me here. The reason I'm here is that God sent me here. What's the appropriate response to that? Or how do you interrogate that to make sense of it?
Why not just accept it?
Why not just accept it? All right, indeed. Why not just accept it? What's the hazard in just saying, okay, that's fine. Since God sent you here, we're going to do it. I mean, well, what kind of God is it, that sent you here? Might be one of the questions you would want to ask. There are lots of them out there, and I'm not sure which one sent you here. Was that a beneficent scorekeeper, caretaker God, or is it some other kind of God? The fertility God maybe sent you here. And that's why, can you ask people that kind of question? You don't think so. Why not? Why can't you ask people that?
You're on the spot.
That's the problem when you sit too close to the front. Well, I guess you could in a respectful way.
Of course.
And so as long as the family feels like you are being respectful and just inquire. I mean, there are many different religions. And
yes.
I probably wouldn't phrase it the way you had, though.
No. I'm sure you would do a better job.
Larry, I might have asked, if I can just, since I've got the microphone, ask, what other centers did your God consider?
That's great.
I mean, in a respectful way, I would
yes.
say, there are other centers. Did you consider them, and why out of the many centers are we your choice? In a way to try to
right.
understand this in a context of whether they really did consider other options before coming to you.
We asked something very close to that, and frequently an answer we got, at UNC in Chapel Hill was, I know the doctors wouldn't be offering this unless they were sure it was going to be good for my baby. So that didn't get us very far in terms of reassurance on the scale that they knew what they were getting into.
As you describe these alternatives, I have a sense that for the family who says, God sent me here, there's a sense that they are not sharing the burden of decision, that the physicians are burdened by the risk-benefit ratio, and they want to be certain that their patients and the family share that burden.
Yes.
And when someone says, God's taking care of it, you have a sense of it's all yours. The full burden is on you.
Yes, yes. It's a very uncomfortable position to be in, because that's a great point. I mean, shared decision-making does say we're both entering this with our eyes wide open, and we're both cognizant as best we can be of the risks and potential benefits, and therefore it's not like something I am deciding for you, which is a hell of a burden to have for somebody. Yes, sir.
I'm not sure about others, but you're raising a whole lot of anxiety here. I'm a child psychiatrist, and my wife is a pastor, so I deal with this all the time, trying to sort out, what are my beliefs? And my belief system is a medically trained, scientifically based religious belief in what I'm doing, if you will. And a part of what you're describing, I think, is that we all develop, a moral, ethical sort of view of the world, kind of envelope within which to try to feel emotionally secure in the world.
Yes.
The more I hear folks say, I just leave it to God, the more my sense is that their moral envelope, their life shield against the vagaries and the dangers in life is more fragile. And we need to be more careful at some level that the sophistication that I believe I have that gives me more flexibility and adaptability, if you will, isn't necessarily available to other folks, but they're still doing the best they know how with the background that they have, the tools that they have from their upbringing and their other capacities to understand the uncertainties. I'm a believer in random events. I don't think God decides which child has spina bifida or not. I don't think it's anything like that. But there are folks that are trying to figure out, why me? And there really is not an answer to that, I don't think. But there are people that need to feel like there is some answer in order to feel that their lives aren't just completely shattered. The other thing that can happen out of this is that they go ahead, God's going to protect me. You have a bad outcome, and their whole religious sort of life safety framework shatters, and this is an after possibility. Right. So that's where the IRB, our concerns about getting sued, those kinds of things to put the risk back in our laps come into play.
Thank you very much for those comments. I think that's exactly right. But you've only heightened my anxiety, because if in fact these people are more vulnerable than the average set of parents, then the question about what to do in relation to, so do we keep them out of the protocol? Are they eliminated?
I think it depends on how we are judged. We are given the flexibility, through the IRB, through the courts, where we aren't, severely penalized if there's a bad outcome, then we're safer to share the decision. If we need to protect ourselves from those horrible outcomes, getting sued and so on, then we need to be more conservative in who gets into the trials.
So, actually, the last comment segues into what I was thinking about. When I was hearing your description of the problem, I realized that this is not unique to an issue just related to being in a clinical trial. This is actually an issue that parents and clinicians engage in every day, and where it comes up, I think, most starkly, although on a routine basis, is in the critical care units, where families are facing life and death decisions, and they often will use this sort of language to describe their decisions. So the question I want to ask you, though, Larry, or to think about, is in the example you're giving, it's where there's a sense that everything else being equal, if the family agrees, we'll go forward and do something. Where I think we often see this in the ICU is in the situation where the clinicians are recommending it perhaps it's time to limit or withdraw therapy.
Yes.
And families are then talking about how beliefs in God and pathways are leading us to make a different decision. I'm wondering whether you think that there's a difference between when the conversations to affirm a decision versus it's to reject a decision that's otherwise being offered?
Yeah, that's a great question. And I don't know, except to say that, yes, I mean, we run the consult service at Vanderbilt, and 85% of all the cases we are called into have to do with end of life, and they have to do very frequently with precisely this. The medical staff believes it's time to stop. The nurses are fatigued. We don't think we're going anywhere, and yet the family says we're waiting for the miracle to happen. And what do we do with that? Now, this, of all the kind of objections or the things that we encountered, this was in some ways the most problematic because not only did it involve the deity, it involved the institution and a kind of faith in the institution that was worrisome in relation to what we might and might not do or permit. And it signaled this sense that, we just wouldn't be doing this unless it was beneficial. That's the thing. And you can understand that. Although it's a clinical trial, people look the same. They're all dressed in white coats. They all are dressed as doctor, and it's all in the same area, the same. Everything looks like it's therapeutic. These are some of the things we tried to learn to say to people, to ask them. Can you imagine learning something that would convince you not to have that? And if the answer was no, then this really worried us even more. There's nothing you could tell me. We had one young woman say, I don't want to hear about the risks. They'll only upset me. This is a kind of person I think we should say, you're not an appropriate candidate for the trial. We're very sorry. But that's a very hard thing to say to people. But if you don't understand the most elementary things about the risk, if you don't even want to hear the risk, this maybe is a rejection of one's own moral agency that we really can't countenance. I mean, this was our feeling in any case. So here's the next one. Very similar to what I said, my faith will protect me from harm. Is this a delusional sense of invulnerability, or is this some kind of, are they talking about really specific harms from the surgical procedure? Are they talking about life harms? Are they talking about the fact that even though there's going to be a lot of harm, I know I'm still kind of cupped in the providential trust here, and everything's going to be okay? It wasn't at all clear. People were saying lots of different things. But there is a tendency, I think, on the fact of all the people involved in these procedures on the professional side to actually downplay the harms ever so slightly because everybody in the trial is invested in the trial. They wouldn't be doing it unless they believed in it. And the surgeons especially had to be reined in frequently in terms of what are you actually saying to these couples? It was... We had actually a prohibition about the surgeon couldn't talk to the couple before they arrived at the medical center because it only increased actually the amount of enthusiasm they would have when they did arrive. And only because we had the IRB imprimatur could we get away with that. But I don't know. What do you all do in terms of the question about understanding harm, and especially if you're doing a trial? I think it's one thing if it's an established procedure, but if you're running a trial, which by definition has different understandings about what constitutes a legitimate intervention and what people need to know before they can participate. Do you all have a standard way, for example, of talking about the downside, the harms, the risks? Yes, ma'am. You have a hint?
Did you
Linda?
analyze what your percent of consent was? So, for example, I participated in a trial where we were trying to get consent from mothers to do something from their babies. And our success rate in obtaining consent was only 1/3. So I assumed we were doing a really good job describing the risks potentially.
I would think so too. I mean, one of our worries is that we're not going to have any declinations. Everybody that comes to the center is going to get enrolled. We didn't, in fact. We had 3 declinations, but I mean, that's still not many. Because this is a really significant, There's a significant risk to the mother and to the fetus. You must have done a great job. That's what I would conclude.
Is there anybody here from the IRB? It's obviously something our IRB works on all the time.
So I guess I have a real concern with this question with the lady who said my dead grandfather is going to be watching over me during the surgery, and if there was a bad outcome, how would she reconcile that with her belief system?
Yeah, exactly. There's a little bit more to this story. This is a fascinating story. This young woman had actually missed her grandfather's funeral in order to come to Chapel Hill to get the evaluation. So there was a reason why she was sort of hypersensitive to his presence. So it just made it a little more complicated. But this is right. I mean, if you affirm what you consider a faulty basis for decision making, do you then leave the patient with a more traumatic set of sequelae from that? It's a great question. I don't know the answer.
I'm noticing that a certain word has been left out of your presentation, which is hope. And, hope is part of the human fabric.
Yes.
So when you say that people are comfortable in their own skin, that encompasses faith, beliefs, culture, and hope. So, hope changes as the circumstance changes, just like faith changes as the circumstance changes. And although some people's faith may be shattered, others may be completely strengthened.
Right.
So I think that it's important not to put everyone in one category.
Thank you. That's
so
absolutely
I'm taking
right.
the plowman's stance. I was just offered a couple of clinical trials for myself. And I found myself looking at only the hopeful part of the data.
Yes.
Not the side effects or the complications. So I think that hope is a really important aspect.
Yeah, the longer version of this talk, has actually a wonderful quote by Emily Dickinson about, hope is the thing with feathers, and so on. It is. Hope is a dynamic I didn't discuss at all, but it's a very important part of this, and how hope was concretized in terms of various outcomes. It's a very important component. We talk an awful lot in medicine about not taking away people's hope, but we don't get much more sophisticated in terms of what would it mean to interrogate that hope just a little, if you can do it gently, politely,
Larry, can I having lived, as we talked about in Memphis, where organized religion is a very public, comfortable conversation. Now in the Northwest, the public organized religion is a little less prevalent in terms of our thinking. And I'm curious how much our anxiety about this is related to the word faith and God when other people are expressing the same thing in different terms.
Great. Yes, thank you very much. And that's why I wanted to expand the notion of religion to whatever interpretive system that is kind of foundational, the kind of language, the baseline kind of most fundamental interpretation of life's meaning and purpose for a person is, because that functions in the same way. And a functional definition of religion is the thing that orients you and keeps you sorted out, hopefully. Well, this is the last one, and again, just a sense about what we were trying to do. Things, you encounter this and you think, what are we going to do next? And these are the probes that we thought were useful. I'm not, as I said at the beginning, I'm not at all certain that we did well by these people. So we would ask, does this mean you can't or shouldn't make a decision about participation? Or what does this mean about the way you're going about this? And so on. But one of the great lessons for me is that you can probe further than you think you can into people's belief systems and rituals and orientations and meaning structures. It's possible to do that, and that's something that actually gives me hope in terms of actually thinking that you can get some assurance about what people are thinking and how they're sizing things up. We can press a little harder sometimes, I think, than many of us think it's possible to do. Even with people you're meeting for the first time. But as I say, this is an ongoing thing for me, and it relates to all kinds of therapeutic maneuvers as well as investigational maneuvers about how do we understand what people are saying to us, and do they really get it? Do they really understand? Are they on board? And can we make them a part of the decision process in a meaningful way? So, other questions? Yes, sir.
Maybe I'm just sort of thinking about it simplistically, but the people that in God's hands they decided not to come to you, they made a conscious decision that God helped them to get to. The ones that reached you, God made a decision to help them to get to you. So whatever belief mechanism they used, they made a differentiating step at some point. It's just that you're just seeing the ones that God led them to you.
We're seeing the ones that God took to Vanderbilt. Yes, that's exactly right. That's exactly right. Because if divine providence is in fact your covering rule for everything that happens, as it is for I think many of these people, then that's right. So we would be seeing the same thing for people who had decided not to show up or who had chosen termination, in fact.
Well,
if that was a part of their system of understanding.
how many of these were diagnosed early enough to offer termination, and was termination offered? That's one question. Another question is, these are young people. They may not have known about folate and prevention, and that would introduce the notion of guilt if they
Yep.
And another thing, follow up. Did you follow up those who accepted and those who did not? And the last comment, this is a comment, not a question. Bruder pointed out that this is this is one of the most unchurched communities in the country, and some of us don't believe that there is any differentiation between faith and fantasy.
Well, okay, let me just start with the last one. And, I think the differentiation between faith and fantasy is often very thin. But I'm not ready to concede that one collapses completely into the other. Yes, there was guilt about folic acid. Even with people who had, really good diets, and you would have thought they would have gotten enough folic acid. These were people who all had a diagnosis in time to have a termination had it been their choice. And in fact, as I said earlier, many of them were very explicitly counseled by their local obstetrician to do just that. And so these are the people who didn't see that as the path. And I've forgotten the middle question.
Did you do any follow-up? I think
Follow-up, yes. In fact, we have followed up with the couples who had the procedure, and now we have a graduate student actually who's following up with Vanderbilt, many of the Vanderbilt couples who chose not to have the procedure, who came to the center and said no. And I think it'll be interesting to see what they say.
Well, unfortunately, our time's up. Let's give a round of applause to our very interesting speaker. Thanks for the audience participation. That was great.
Thank you.